electricity.
Bismillah ar-Rahman ar-Rahim. So it's a pleasure and honor for us to have Professor James Lau from the Chinese University of Hong Kong. Most of you have seen his studies. He has landmark trials in the use of PPIs in GI bleeds. He also a number of publications in very high impact journals in advanced endoscopy. He's a surgeon by profession and a professional endoscopist, I'll have to give him that. And he's the head of the department. So without further ado, please, Professor James Lau.
Thank you, Professor Almadi, for a kind introduction. I'd like to first thank the Society Organizing Committee for a very warm hospitality, and it's really an honor and pleasure to be here in Saudi. My talk today, may I have my slides, please? My first talk today is on the novel endoscopic therapy in the management of acute non-invasive upper GI bleeding. We, in fact, learned from Professor Nip Suhendra, the credit belongs to him. He published the first account of endoscopic injection therapy in 1977, and that was 40 years ago. The gentleman to the far right, my predecessor, Professor Sidney Chung, learned the technique and published the first randomized control studies in British Medical Journal in '88. In a sham control study, they demonstrated that the use of diluted epinephrine in 64 patients, in fact, reduced the need for surgery. And injection of diluted epinephrine is in itself quite an easy technique to learn. You just need to inject small aliquots of diluted epinephrine around the vessels. And then we went on to refine the technique, and it took us many years and many clinical trials, and also a meta-analysis to realize that the injection of diluted epinephrine itself is an inadequate therapy. And as you can see from these forest plots, and all the dots are towards the left, by adding a second modality to target the vessel, we can further reduce rates of recurrent bleeding, surgery, or mortality. That is very important because in this meta-analysis, this represents a 50% reduction in mortality. So this is a video, an old video on the use of a thermal device. It is, in fact, a time-honored device, and we continue to use this. It was pioneered by the UCLA group in the United States. The technique is, in fact, to irrigate until you see the artery clearly, and the important component of this treatment is the mechanical compression before you activate the thermal energy, and we use a continuous 4 pulses until we see a very nice footprint to the outer base. And this is a schematic representation by James Johnson's group back in 1987. Again, a firm compression of the artery, reducing the heat sink effect before you activate the thermal energy and leaving a footprint in the outer base. And he coined the term coactive thermal coagulation. And this technique we continue to use nowadays. The use of clips was first described in 1983, and that obviously early days, the clips were a little difficult to use, and they've continued to evolve. And now we have very large clips that opens to about 2 centimeters in width. And this is a video of therapy. This is a duodenal Delacroix lesion pre-injected with diluted epinephrine and with a large clip, and you can see that the hemostatic effect is, in fact, very good. How to choose between clips or thermal coagulation, we don't really know, because when we did a meta-analysis some years back, combining all the clinical trials that compare head-to-head the use of clips versus thermal coagulation with or without injection, and this is a forest plot on the rate of definitive hemostasis with pool odds ratio of exactly 1 to indicate that the two modalities are equally comparable in the rate of definitive hemostasis. I think the choice is really on practical considerations, and I found the use of thermocoagulation better in chronic ulcers with very fibrotic ulcer base, and clips to be a little better when you see a very prominent vessel. This is a new device that we've came to help to develop. This is a use of hemospray, and this belonged to a patient who had quite significant bleeding from an angular notch ulcer, and the endoscopist had difficulty controlling bleeding, and after a little while he decided that hemospray would be used, and this is a 3.2 millimeter catheter coming close to the ulcer itself and spraying the powder. And the powder is in fact FDA approved for external use, and we actually published the first human study several years ago. And this is after 5 minutes observation and that the bleeding had stopped. And in this particular patient, we took him back and we examined the ulcer the next morning, and this is what we saw, and that the powder had been completely washed away, and you could see the remnants of the thermocoagulations and the remnants of the bleeding artery itself. And one can choose to add a second modality targeting at the artery itself. Here I've summarized the literature. The first account of use of hemospray came from our unit in 2011, published in the Journal of Endoscopy. Then we recruited 20 patients with Forest 1 bleeding from their peptic ulcers, and the hemostatic rate was in fact quite good. In 19 of 20 patients, we managed to stop bleeding. And subsequently, there were many series, including the one published in 2013. It's a European registry. I've here summarized literature. The initial control rate, the acute hemostatic rate, it was in fact quite good. That's about 90%. Unfortunately, the rate of further bleeding in this pool analysis was about 20%. So it is a general belief that if you have difficulty controlling bleeding, you could use hemospray, but it would be advisable that you bring the patient back the next day and perform further therapy to the underlying bleeding lesion. And our group has been involved in a randomized control studies. In fact, I designed the study. I designed the study with a hypothesis that hemospray would be non-inferior to standard therapy in bleeding from acute non-varicose sources. This is an interim analysis consisting of 120 patients with more than, about 60% of them were ulcers, and there were some cancers and others. As you can see from this Kaplan-Meier plot, the acute hemostatic effect of hemospray was in fact quite good. It was 100%. There were about 5 rebleeding in either group. It's about 8%. And when we followed patient up for 30 days, there was really no difference. So this is the first ever randomized control study to use hemospray as the primary therapy. We are halfway through the clinical trial, and hopefully we should be able to publish the results when we reach the target sample size of about 250. This is another device called the Overscope clips. It is a 19-0 clip, otherwise known as a bear claw. It's housed in a transparent hood mounted on the tip of the endoscope, and you have a cogwheel. The deployment is similar to that of the 6-shooter that one would use in band ligation. So you just have to turn the cogwheel, and there's a trip string that will retract the cap, releasing the clip itself. And here I have a video. Would you start the video for me, please? Of a major bleeder, and this patient, in fact, had undergone surgical plication. He underwent surgery to his gastroduodenal artery, and he came back with further bleeding. And I tried to slow it down with a little bit of injection, and obviously it did not work. And here you see the clip mounted on the end of the endoscope and going down. And at 6 o'clock, you can see a trip string And the trick is to scan the area until you see the bleeding point coming into view. And with the turn of the wheel at the head of the endoscope, you pull the string, and then the transparent hood retract, releasing the metal clip. Here you can see the immediate effects, and it actually incorporates quite a large amount of tissue going around the gastroduodenal artery with a little bit of the suture material left on the outer base. And we are now seeing evidence that it works in refractory bleeders. Arthur Smith from Germany, and we are part of this multi-center study, presented this paper in refractory bleeders. It's a multi-center German study plus Hong Kong. It's a randomized control study in refractory bleeders with a sample size of about 59 patients. And in this study, the initial hemostatic rate with over the OTSC clip and also freedom from bleeding within 30 days were significantly better with the OTSC. And you can understand that because the clips tends to stay for a long time. And if you happen to scope the patients a few months later, and the clips would still be there. So this is a device that we use for endoscopic gastroplasty, anti-obesity treatment, and this is called the overstitch device. It actually came from the Eagle Claw developed by the Apollo groups many years ago, and we were involved in its design, and the copyright subsequently sold to another company. With this device, you can in fact perform a running stitch. There's also you can actually tighten the suture, and there's a cinch device that allows you to cut at the end of the suturing. In the interest of time, I'll just move on. We published would you please start the video? We published in the video gastroenterology the technique of actually sewing it. It's now possible to oversew an ulcer, much like what a general surgeon would do. And this is a figure-8 stitch starting about 11 o'clock and then going to 7 o'clock and then going back to 2 o'clock and then 5 o'clock, and then we plicate the ulcer in a figure-8 manner. So it's very nice to be able to publish it and to say to people that you can, now we can suture an ulcer, but in reality, when we try this onto a duodenal ulcer, for instance, with this very cumbersome suture device, it just wouldn't work, and perhaps it would only just work in large gastric ulcers. We've done a number of these cases, but the true merit of this technique remains unknown. So I'll show you a picture of what it appears after the ligation, and this is, we've actually pulled the mucosa together, and this is the end results. And lastly, I'd like to speak on this technique. This is a video from Professor Kenneth Bimula, and I like the concept of EUS-guided angiotherapy. And he had a patient with dural lesion in the proximal fundus, and he was able to image underlying bleeding vessels and injected the bleeding artery with the slow polymerizing histoacrylic glue called the dermabond, and that this patient had no further bleeding. And in the literature, there are anecdotal reports of selected cases where angiotherapy would be successful. I think with improved resolution of EUS machines, I think this would probably evolve as one of the treatment options. So, ladies and gentlemen, if I can conclude that, I think nowadays the hemoclips and thermocoagulation are the current standard. Hemostatic powders are useful if you struggle to control bleeding, and but it should only be considered a temporizing measure before definitive treatment. That patient should undergo a second look. Although we are actually working on RCT, and before the RCT, the patient should undergo a second look endoscopy with the view to treat the underlying vessels. I've shown a video of large tissue capture device for refractory bleeders, and we have the STING study to be published to support its use in refractory bleeders. I think US angiotherapy would probably be something in the future, and it's worth investigating. Thank you very much for your attention.